Okay, well, thanks, guys. Excited to be here, and at last count, there was exactly 26 people in the room, including the four of us, and the number's increasing. There's 28, 29, so I'm excited. It's actually better than last year. Not as good as Craig when you did it, so I think I'm still behind. There was about 100 people in the room. So thanks, guys. Obviously honored, humbled to be receiving this, some disclosures that don't really mean anything here. I will say that there are huge shoes to fill in because the previous recipients of this award, at least one who I know is sitting back there in the audience, Dr. Cooper Smith, and there's several others as well, and I don't know if I'm in the same league, but I'm gonna tell you a little bit of my story, how I got to where I am, and hopefully that'll either inspire some of the younger generation or some or not. Did I say younger? I shouldn't have. Anyway, the first part of this is serendipity. I believe that everything happens in life for a reason or for no reason at all, and for clinician scientists, sometimes it's all just serendipity. Certainly my life it's a lot of chance happenings, and if you look at this guy who started the top left corner of your screen, and then that's me in medical school, look at the hair and no glasses for a while. And the bottom guy who wanted to be a cricket player, and then this guy who went mountaineering quite a lot in the Himalayas. I grew up in India. And then the person that has sort of metamorphosed into this guy who, like my wife says, you just love talking and standing in front of the mic. So it's been quite a journey that started in this city called Chandigarh in the northern part of India, close to the mountains, and then went all the way over to Northeast Ohio, to Cleveland, and then to Wake Forest. So it's been a journey that has taught me a lot, and it's been very, very interesting. The other part of this is reverse causation. So for those of us who deal with statistics, reverse causation typically is a seemingly causal relationship where the effect influences the cause rather than the cause influencing the effect. So in my life, this was reverse causation. This was the effect. This was 2 years out of fellowship. I was the first author on this paper in the New England Journal. Some of you have read this, the ATHOS-3 trial. We showed that angiotensin II effectively increased blood pressure in patients with visitatory shock. And wow, you had your name on the very famous New England Journal. Now, little did I know at that time that back in 1957, so I was at Cleveland Clinic when we did this trial. Back in 1957, at the Cleveland Clinic was where these gentlemen, Irvine Page and Arthur C. Corcoran, actually made the molecule angiotensin II. They called it hypertensin back then because they were very worried that this agent causes hypertension. They just wanted to fix the hypertension. They didn't really think about vasodilatory shock and try to fix hypotension. I didn't know any of that in 2017. Someone else educated me on it, said, wow, that's really interesting. Anyway, the story goes on. Then we started thinking about renin. So this was an interesting finding with the ATHOS-3 trial. In patients who received placebo, there was no change in renin at all, whereas patients who received angiotensin II, the renin fell dramatically between baseline and R3. So for your understanding, it's the cascade, angiotensinogen, renin, Ang1, Ang2. So if there's a deficiency of Ang2, renin increases. We give Ang2, renin goes down. This was further made interesting by this post hoc analysis with Rinaldo Bellomo, where we saw that in patients who had renin more than population median within the ATHOS-3 cohort, if you randomized and looked at those patients only, there was a survival benefit in patients that received angiotensin II, meaning thereby renin was a marker of mortality. When you gave angiotensin II in patients with high renin, there was a survival benefit. So all of this started getting really interesting. And I'll dive into a part of the renin-angiotensin pathway that a lot of us in the room probably don't know. This is the classic pathway that we all study in medical school. But the ACE2 pathway is the non-classical pathway. So it produces angiotensin 1 to 9 and 1 to 7 that are vasodilatory in nature, not vasoconstrictive. Now, why am I bringing all of this up? Because the next part of the serendipity journey takes me to Wake Forest in early 2019, where I meet this man. This man is Professor Mark Chappell, second author there, and then Carlos Ferrario, who's the first author there. And they, back in the 90s, actually discovered the Ang 1 to 7 side of the pathway. So, all serendipity. I didn't know this when I went to Wake Forest that they were there. They met me. They said, wow, this is interesting. You worked with exogenous Ang2. You've done the trial. We're the ones who worked on the RAS alternative cycle. Very simply, what these guys suggested was angiotensin 1 can get converted to both Ang2, which is the hypertensive side of things, which is the vasoconstrictor. It can also get converted to angiotensin 1 to 7, which is antihypertensive, which is vasodilatory. So we went on further. We started using other data to look at RAS. So I'm going to quickly show you some work. This is the very famous Victus trial. We used biorepository samples with Victus. We got Mark Chappell and his lab to look at the RAS behavior in patients with Victus, who are part of Victus. We saw exactly same signals as others had, that renin was a marker of badness. So as renin increased, there was almost a linear relationship here with increasing renin and the hazards of mortality. Furthermore, we saw median renin over the course of the trial. Again, same issue, high renin, poor survival, low renin, better survival, same with increasing or decreasing renin trends. The most interesting thing we saw here, and I bring this up again and again, is that there's a total disconnect between increasing renin and downstream angiotensin 2 production in patients with septic shock. This is data from the Victus study. It's on the supplement of that paper. You see how renin goes up to 60 times here in the patients who do the worst in the Victus group, but Ang2 doesn't, it's all flat. No, there's a pure, this tells you that there is a diversion to the side pathways, and we did see that. We did further KM studies here. We saw that ACE2 and DPP3 are highly activated in patients with septic shock, so they divert to the vasodilatory side of the cascade. So what Mark Chappell and I are now working on is that RAS dysfunction is multifactorial. So part of it is because of ACE dysfunction. ACE is majorly produced in the lungs, so part of it is ACE. Part of it is angiotensinogen produced in the liver. That's probably down as well. And the other part is the kidney, so there's a degradation in the AT1 receptors. So these three probably come together. We've produced further work, again from the Victus cohort, that shows that it is low angiotensinogen that is the most superior marker of survival, even better than renin and lactate in patients with septic shock. So here, AUC-ROC of angiotensinogen is the most predictive of overall survival compared to renin, and lactate is really not good at all. This is another comparison of the survival curves right here. And furthermore, we're also taking a deeper dive into ACE, ACE2, and DPP3. We're seeing ACE dysfunction, ACE2 increase, and DPP3 increase in patients with septic shock. So there's a lot of information. I just wanted to show you what's going on. It was definitely a sort of a surreal moment for me when we produced this review article with Rinaldo, Alex Zarbach, Mark Chappell, and others, again, talking about the entire cascade. This is my current collaboration with dysfunctional RAS and septic shock, made up of clinician scientists at Wake Forest with Rinaldo and Alex Zarbach. And then this extremely bright individual, Daniel Leisman, who's at MGH. Watch this name. I tell him he's going to be a Nobel laureate in critical care. He was finally a resident when he started producing papers on RAS. He's now a pulmonary critical care fellow at MGH, and absolutely brilliant in what he does. We all came together, and we submitted an R01 last year. Based on the timing of all of this, I should have had a notice of award on my slides today, but I don't have a notice of award. We are pending a notice of award. We've got a really good score. We're hoping that this will all translate into something good. So I'm still searching for, is renin the new lactate? Going on further, we've done work with renin in post-cardiopulmonary bypass vasoplegia. This is the group that gets vasoplegic, the bright green dots here. Totally flat renin response, no increase in renin at all, shows a lack of production of angiotensin II downstream in patients with vasoplegia. With the group at Duke, we're also looking at RAS dysfunction as a predictor of outcomes after lung transplant. So the story and the journey goes on and on and on. But there is inspiration, and a lot of inspiration along the way. Just want to highlight all of these individuals. Some in the leftmost corner of here, you'll see some of these on the slide. Doug, I see you. Some of my earliest teachers in critical care at Cleveland Clinic really formed and shaped my career. Doug especially tortured me at several occasions to get involved with SCCM. Doug, it worked, thank you. That's my dad. He's 86 years old now. He trained in vascular surgery in the US and went back to India to set up vascular surgery in that country. I've always wanted to be like him. I don't think I'm even 20% close to his brilliance, but I try. That's him last year, me and him in the US over a glass of beer. He enjoys that. And my family, my kids are much older now, the twins and the elder one, and my lovely wife who's watched all this madness happen and still believes I'm just a narcissist and nothing else. And then this is Mark Chappell, and that's Dan Sessler, who really got me interested in clinical trials back at Cleveland Clinic, and still regard him as a mentor. And it's a road less traveled, because my journey started with industry. Paper here says interdisciplinary perspectives on industry-sponsored research, right? And yes, my journey started with industry, but went back to the NIH. Not a typical pathway, but that's the way, how I've been shaped. Eternal gratitude to a lot of individuals. Oh, what happened here? What happened here? Why is this hand on here? It's probably a... oh, sorry, guys. Trying to move the hand. Okay. Did I press something I shouldn't have? I think so. Get out of here. Okay. All right. Works. All right. Eternal gratitude to more, friends like Piyush who've stood by me in good and bad times, importantly bad times. My three kids, Ane, Ayush, and Nahan, these guys, they're twins, they're 8, and Ane's almost 11 now. My lovely wife, and friends I've made with SCCM. Here are my two funny co-chairs. You recognize them, but co-chairs are best friends, and I've made great friends through the society. And my lovely research team at Wake Forest, they power all of this, and I couldn't have done this without them. So, thank you, guys. Thank you for your listening.
Wonderful, thank you. Okay, that was terrific. I don't know, you don't strike me as a narcissist, but I'll have to talk to your wife.
Meet my wife, she loves something else.
All right, our second panelist today is someone I'm thrilled to introduce you to. Whitney Gannon is here as the Discovery Grant recipient. Whitney is a nurse practitioner and clinical researcher with an appointment in the Division of Pulmonary and Critical Care Medicine at Vanderbilt University. She has expertise in extracorporeal support for pulmonary and cardiac failure and serves as the Associate Director of the Adult Extracorporeal Membrane Oxygenation Program and the Director of the ECMO Research Program within the Pragmatic Critical Care Research Group at Vanderbilt. Her research has focused on understanding ways to optimize ECMO care for patients with acute and chronic respiratory failure and improving ECMO outcomes, ECMO patient outcomes. Whitney's going to be speaking with us today on her ECMO-Free trial, a multi-center pilot feasibility study. Come on up, Whitney.
Thank you so much, Karina, and everybody for listening to this talk today. Just pull it up here. Okay, so today I'll be discussing the ECMO-Free trial, a multi-center pilot feasibility study that was conducted through the generous Discovery Grant Award through SCCM. I have nothing to disclose. Just to provide a little bit of context to the talk, veno-venous ECMO is an extracorporeal mechanical device that includes an external source of gas exchange, and it is provided to select patients with severe forms of respiratory failure. Especially in recent years, ECMO is common, and the use of ECMO and sort of the ability to provide ECMO is only increasing by a lot every year. In the past decade, we've learned data is showing that there's very likely a subset of patients with acute respiratory distress syndrome in whom ECMO may be life-saving, and it's important. Yet, ECMO mediates and causes a myriad of complications, and the risks of these complications increases with time on ECMO. ECMO is also an intense resource and associated with high costs. So therefore, it's really crucial to be able to identify when patients are ready to be liberated from ECMO at the earliest, safest possible time. Current approaches vary. They're somewhat arbitrary. They rely on clinicians to identify readiness to liberate and rely on kind of small iterative downgrades of support over time and really are not supported by very much data. So we've learned some important lessons in other realms of critical care when it comes to liberating from therapies. We've learned some important lessons in particular in mechanical ventilation. So we've learned that clinicians underestimate the patient's readiness to wean. We've learned that single predictors to identify readiness of successful liberation are pretty limited. In general, daily liberation trials, protocolized assessments are best, and systematic and standardized approaches lead to improved outcomes. This concept was borrowed from spontaneous breathing trials and mechanical ventilation literature and applied to the veno-venous ECMO space. These are two pilot trials, one by our group at Vanderbilt and one by Eddie Fan and Ricardo Paradis in Toronto. And it essentially did the same thing where this was just sort of a single center, one arm feasibility study. Can we execute this protocol? And there were little different specifications of the protocol, but ultimately found that this was feasible and may help us identify readiness to decannulate patients from ECMO sooner. So we decided to kind of join forces, and we also joined with Matt Precker and Sydney Hansen from Hennepin, and conducted the ECMO-Free trial. It's a multi-center pilot feasibility study, and we were very fortunate to receive the generous Discovery Grant Award to perform this study. We really wanted to know, well, does this concept of applying a once daily protocolized assessment of readiness to wean also apply to ECMO as it does in these other kind of spaces in critical care medicine? Our primary aim was to demonstrate feasibility of a large multi-center randomized controlled trial by conducting a multi-center pilot trial. Our secondary aim was to kind of specify and define and estimate the frequency of the primary efficacy outcome, primary safety outcome, and secondary outcomes that we might use for a large multi-center randomized controlled trial in the future. So we performed a multi-center parallel group unblinded pragmatic pilot randomized controlled trial comparing once daily protocolized assessment of readiness to liberate from ECMO to usual care. we casted a pretty wide net. We really included all patients receiving veno-venous ECMO with a few exclusion criteria, so pregnant or prisoner, patients receiving ECMO for over 24 hours, patients receiving ECMO as a bridge to lung transplant or heart transplant. And this was done with IRB approval via informed consent. So our interventions, patients were enrolled and randomized to receive either usual care or the ECMO-free protocol. So in usual care, weaning and liberation strategies was directed by the treatment team, and the ECMO-free protocol was delivery of this protocol once daily. And I'll go into that in a little more detail. So this is pretty similar in terms of, conceptually to a spontaneous breathing trial. It included the first phase where it's just a safety screen. So a list of criteria, and if the patient passes this safety screen, they can move on to where the gas exchange would essentially be turned off in ECMO. And so these criteria basically reflect what is safe, what do we feel like is safe in order to proceed. And so, for example, patients with a sweep gas flow rate of over 4, kind of representing very high support, ventilator FiO2 greater than 60%, representing, the patient's in a pretty early kind of acute phase of their illness. It might not be ready time to do these trials yet. So if all criteria are met, or no criteria are met, no failure criteria are met, they move on to the second phase, which is non-ECMO respiratory support titration. And I think everyone probably can acknowledge that, in the ICU, even for acute respiratory distress syndrome, somewhat the ventilator can be managed somewhat variably, I think within the bounds of lung protective ventilation, hopefully. And so this allows for clinicians to have the opportunity, if they choose, to sort of optimize the ventilator within the bounds of there's kind of thresholds, but within the bounds of lung protective ventilation to offer the patient the best possible opportunity to pass their ECMO-free trial, essentially. And so they can increase, ventilator pressures, volumes, or FiO2 within a certain threshold. And if they still don't meet any failure criteria, they move on to ultimately the ECMO-free trial, where there's an intermediary step where the blood flow rate is turned down just to make sure there's no kind of rapid hypoxemia for 5 minutes. If the patient still, there's a list of failure criteria during this trial. If no failure criteria are met, the sweep gas flow is turned off. And so essentially what that means is no gas exchange is occurring through the membrane lung. And so it simulates what the patient would be like, if they were not on ECMO without actually removing the cannulas. And so the patient receives an arterial blood gas at 30 minutes and 4 hours. The trial kind of continues until the first of failure. So if a failure criteria is met, the trial's over. If they don't meet a failure criteria, the trial is over in 4 hours, and you sort of deliver this result to the treatment team. The trial does not direct decannulation from ECMO. This is just information that's provided daily to the clinical teams. So we specified our primary efficacy outcome as 60-day ECMO-free days. Our primary safety outcome was unsafe liberation from VV ECMO, and we used a very kind of elaborate definition borrowed from data, or this kind of definition used in work by the Toronto group in a previous paper. And feasibility outcomes: can we enroll? Can we separate between groups? Can we adhere to the study protocol? So I'm going to share some of our feasibility results today. So we screened 137 patients, or 138 patients. We excluded 48 patients, 90 patients, so 65% of those who were screened were randomized, and 45 were randomized to receive usual care, and the other 45 were randomized to receive the ECMO-free protocol. Baseline characteristics were quite similar between groups. We did have some sort of random imbalance in indication for ECMO across particularly ARDS and patients receiving VV ECMO post-lung transplant. Our protocol adherence was excellent. 100% of patients who were randomized to receive the ECMO-free protocol did receive a daily protocol, and 100% of those who were randomized to receive usual care received usual care. So in summary of our kind of pilot phase, the ECMO-free study exceeded kind of expectations in terms of enrollment, met other feasibility markers, And so, but we don't know whether this is better. We need to perform a large multi-center randomized trial to determine safety and efficacy. And so we've actually crossed into that next phase, and we've transitioned the pilot trial into a large randomized definitive study. So we started the pilot trial in September of 2022, ended the pilot trial in September of 2024, transitioned to the definitive trial. We took kind of 2 months. We paused enrollment for 2 months while we got up and running with our IRBs. Same with at Hemorrhage in Toronto, and started expanding to 8 to 10 additional centers. And so we transitioned the definitive trial to December of 2024, and we expect to complete the trial probably fall of 2026. So really there aren't changes to the study intervention or the protocol itself, but we did, of course, increase the sample size. So we calculate, based on our power analysis, our sample size is expanding to 225 patients. We are expanding, we're adding about 8 to 10 additional sites in the US. And we've also respecified our primary outcome to time to successful discontinuation of ECMO within 60 days. And so 60-day free ECMO days will become a secondary outcome. And so I just kind of wanted to end with kind of a thank you to SCCM, and just wanted to summarize the impact of this work. So thank you for funding this important work. In addition to funding the successful completion of this pilot study, really the funding that we received helped to establish the first US clinical trial network focused on ECMO among critically ill adults. We expect to complete this very large definitive study in the fall of 2026, and we continue to add sites to this newly formed network, and it's really allowed us, to perform this study on a large scale and also future studies. So thank you all very much.
Thank you, Whitney. That was terrific. I forgot to mention when I was introducing Whitney that I knew her when she was a graduate student at the University of Pennsylvania many, many years ago. So it's really an honor to be able to introduce her today and hear about the incredible work that she's been doing. So our third and final speaker then is Dr. Jose Javier Provencio, who told me I'm not allowed to read his total bio. So I'll be very brief, although he's deserving of all of it. Dr. Jose Javier Provencio is the director of the Naranci Neuroscience Intensive Care Unit and a translational researcher in the Department of Neurology. He serves as the division head for the Hospital Neurology Division of the Neurology Department that includes the ICU and hospital neurologists, and the medical director of the Naranci Neuroscience Intensive Care Unit and the Neuro Intermediate Care Unit. Nationally, Dr. Provencio serves as a member of the Strategic Planning Committee of SCCM. He's the co-chair of the Grants Subcommittee of the Neurocritical Care Research Central and is on the steering committee of the Keurig-Comig campaign of the Neurocritical Care Society. He serves on the editorial board of the CHEST-Seek Critical Care Medicine Self-Education and Evaluation of Knowledge Review series, and is on the editorial board of the Jurors of Neurocritical Care and Translational Stroke Research. He's here today as the Weil Research Grant recipient, and the title of his talk is Small Molecule MPO Inhibitor to Prevent Delayed Cerebral Injury After Subarachnoid Hemorrhage.
Thank you for that introduction, and I want to thank the Society for funding me in this research. We're going to talk a little bit about this, and I'll show you sort of where we are right now, but this funding was critical for the next steps that we want to go through. So I don't really have any disclosures that are pertinent to this. There you go. So aneurysmal subarachnoid hemorrhage disease that probably all of you see. And it's not a most common disease in the world. It's only 15 to 20,000 people per year. Worldwide, it's actually a bigger disease. The median age is young, 50. So the amount of the years that people live afterwards that they could suffer from the sequelae of this disease are actually quite large. And we know that some proportion of patients who have aneurysm ruptures die right at home. Some of them come to the hospital and die either from hydrocephalus or intracranial edema or complications from their ICU stay. A good proportion of them have a poor outcome. And then there's about 20 to 25% of them who are supposed to have a good outcome, although I'm going to show you that good outcome may not be all it's cracked up to be. The most important thing about subarachnoid hemorrhage, we're going to be interested in this as a disease to study, is that Delayed cerebral, what I call delayed cerebral injury, what people call vasospasm or delayed cerebral ischemia, is still the most the untreated entity after subarachnoid hemorrhage that had the biggest impact, we think, in outcomes later. So this is a disease that begins not at the beginning of the hemorrhage rupture, but has a quiet period, about 1 to 4 days, and then there's a period where patients develop vasospasm, about 50% of them. Some of them will go on to have strokes. About 13% of total subarachnoid hemorrhage patients go on to have strokes, usually small ones. About 30% of patients have neurological deterioration, some of them with vasospasm, some of them without. And then the cognitive deficits, which we'll talk about in a little bit. But the process seems to start from the initial ictus and evolve. It's not something that starts as the manifestations are delayed, but the ictus probably is important. So ultimately, this is a very important disease because it's modifiable. It happens right with the patient in front of us. Importantly, it's called vasospasm specifically because if you do an angiogram at the time of the hemorrhage when they do the aneurysm clipping or coiling, and then you do one during the period of vasospasm, the angiogram looks very different. And if you ask people why this is called delayed cerebral ischemia, they all do the same thing. They all say, they all look at that, but I'm going to show you some data to suggest maybe that's not the case. Because up until now, the theory is, and to this day, the theory and all of our treatments are based on this model. You have a subarachnoid hemorrhage, you develop vasospasm. Vasospasm causes cerebral hypoperfusion. Cerebral hypoperfusion causes delayed ischemia. Well, we've got some drug trials that are a little informative with this. We've got a drug that we use called nimodipine, which does not affect vasospasm at all in actually now 4 trials, but does actually improve outcome. We've got 2 drugs, nicardipine and endothelin-1 antagonist, clazosentan, which actually decrease vasospasm. In the case of clazosentan, almost completely obliterates it. Yet the patients don't do better. So it's weird. We can fix the patients without fixing the blood vessels and fix the blood vessels without fixing the patients. Kind of hard to make it a vascular disease. In addition to that, we base a lot of this on MRIs that we do late, these strokes that we see. But Jen Frontera in New York did this really interesting study where she took subarachnoid hemorrhage patients and she did an MRI during that quiet period between the ictus and the vasospasm. And what she actually found was that the majority of strokes, 61% of them, actually happened prior to the period of vasospasm. And that of the patients who had increased stroke, who had original strokes, the increase in volume was 0.15 milliliters of stroke volume, which is really inconsequentially small, unlikely to cause a major stroke syndrome. More importantly, and I find this data the most compelling, there's these really elegant studies that were done by Raj Dar at Washington University in St. Louis, where they put patients who were in the period of vasoaggressive vasospasm in a PET scanner, and they actually looked at the blood flow. And what they actually found was that patients who didn't have vasospasm had better blood flow than patients who had angiographic vasospasm. So there was a significant difference between those 2 groups. Interestingly, if you look at the CMRO2, or the ability of the metabolism of oxygen in this tissues, it was actually the same. And that has to do with the fact that the oxygen extraction fraction was actually higher in the angiographic vasospasm. So all this data kind of holds up until you look at this. This is ischemia. So if you actually look at this is the same, for cerebral blood flow, this is using the same units, that you develop penumbra at about 20, you develop critical threshold about 12, and you actually develop infarctions at around 8. And although 38 is less than 47, 38 is not anywhere close to 8. So and it's actually very close to normal. So this is why I got interested in maybe this isn't a vascular disease, maybe this is something different. The other bit of data that's new, but it actually was founded on a bunch of other data, suggests that patients with subarachnoid hemorrhage have a really disproportionate cognitive bad outcome. So these are patients with subarachnoid hemorrhage, so they're very typical, more women than men, age around 50, like I told you before. And this World Federation of Neurosurgery score is a clinical grade. It shows the severity of the illness when the person first arrives. 1 is good, 5 is moribund or close to death, right? So it's based on GCS. And if you look at this, they took only the patients who were gainfully employed when they had their subarachnoid hemorrhage. So 81% in the best group were employed fully, and 18.3% were employed partially. If you look 3 years later, and this is 3 years later, 43% are fully employed, 33% have not returned to work. in the best group. These are patients who are awake and alert and sit in the hospital wanting to go home. If you look in the more severe cases, it's even worse. In the moribund case, and even in the WFNS4, 64% of patients don't go back to work. WFNS3 is a bit of an outlier. It's very hard to get into that group. You see there are very few patients in there. But even in the 2s, 50% of patients don't go back to work. That doesn't sound like a stroke syndrome. So we got interested in what else could it be. So the last 15 years I've been studying what else could it be. And we started by looking at inflammation. And there's a lot of evidence that inflammation is correlated with patients who will have vasospasm. Dating all the way back, if you look at these references, back to 1987, we knew that white blood cells were correlated with this late vasospasm event. Cytokines have been looking. Alex Choi's done some really elegant data looking at different cytokines and figuring out patterns. We got interested in looking at cells because I'm more of a cellular biologist. And what we actually found was if you look in the spinal fluid of patients with subarachnoid hemorrhage, that those who have vasospasm, because that's what we were doing, have a much higher percentage of neutrophils in their CSF than patients who don't. And that's actually quite predictive of who will actually have a poor outcome. So based on that, and actually, so it's interesting, Rafael Tamargo, who is a neurosurgeon at Hopkins, did a lot of this work in the 1980s and 90s and drew this picture, which is just frankly prophetic, and never got quite the credit he deserved. So we decided at that point that I needed to do a mouse model because there was no way to do this in humans anymore. So we developed a very unique mouse model, one that we could actually investigate behavior with. So it's a mild subarachnoid hemorrhage model. And what we actually found was that the mice were very similar to humans in the fact that they didn't have vasospasm at day 1 or day 3, but they did at day 6. This is a Barnes maze test, which is this tabletop test over here. It's very similar to a Morris water maze test. It's a test of learning and memory. And what they found is that initially the mice with subarachnoid hemorrhage were really blunted, but they got back to almost normal, and then they started getting stupid again around the period of vasospasm, around the period of delayed cerebral injury. And interestingly, when we did electrophysiology in their actual slices of their brains, we actually found that at day 3, their ability to entrain long-term memories, long-term potentiation, was spared. At day 6, it was impaired. Now, we were interested in neutrophils, so we did a relatively simple experiment. We depleted the neutrophils. And again, I'm a clinician, so we did this after the hemorrhage, not before. I wanted to see if this was a treatment. And if we depleted the neutrophils from the blood 3 days after the hemorrhage, you'll see the blue line, the subarachnoid hemorrhage mice with the neutrophil depletion after the hemorrhage came back to normal as though they were shams. Interestingly, when we did electrophysiology on these, they had retained long-term potentiation. Their memory circuits were still intact. We were pretty happy with that. So the next question we asked is, what about neutrophils are actually causing this? What is, neutrophils make a lot of things and release them. So we actually took a bunch of null mice for different neutrophil effector molecules, elastase and NADH oxidase and myeloperoxidase. And we found is that none of the null mice actually worked, except for the myeloperoxidase mice. Interestingly, using the same Barnes maze, just to give you an example, they were still stunned early on, but around that 3 or 5 day period, they started to look like shams. So they got better. They never had that secondary blip of the worsening. So we were pretty excited about that. Interestingly, and this is, I think, the proof of concept is, if you take an MPO null mouse, and when you give it the hemorrhage, because we do the hemorrhage by causing a nick in a blood vessel inside the subarachnoid space, and you instill myeloperoxidase, the actual enzyme, into the CSF, the mice get back their damage. So we can actually show that we actually give it back to them. And then one of the things we thought was really interesting is that we kept saying, well, let's find out where the neutrophils go in the brain, and we can find a cure for this. There are no neutrophils in the brain. They never actually get into the brain in subarachnoid hemorrhage. In mice, actually, or in humans, if you do autopsy specimens. And interestingly, what we did find was that they accumulate in the meninges. So we get these really high numbers of neutrophils in the meninges of wild-type mice that don't accumulate in the myeloperoxidase mice. And so what does myeloperoxidase do? It's a relatively simple compound. It's a big molecule. But ultimately what it does is it catalyzes the reaction of peroxide or superoxide with some halogen to make bleach. Interestingly, actually, in the brain, it uses bromide more than it uses chloride. But it also does other things. It's a signaling molecule, and in a way that we're just starting to really appreciate in work done in sepsis and in spleen injury. So this is our model that we developed. We have a hemorrhage that occurs in the subarachnoid hemorrhage, in the subarachnoid space or in the CSF space, that causes neutrophils to enter the meninges, and then downstream we know that there's loss of long-term potentiation, and that's the memory deficits that we see in our mice. We've got some evidence that astrocytes may be a mediator in between these things that I'm not going to show you today, but that gap, the CSF space you'd think is pretty small, but it's not really. It's actually a really big place. And so we got interested in how we can fill that gap, and that's what this grant really did. So we asked the question of how do harmful signals cross that gap, and then can we treat with a myeloperoxidase blocker and have the same effect that we do with an antibody? And so I'm going to take 2 seconds here and tell you about what I call the marvelous meningothelial cell. So the arachnoid layer is made up of the meningothelial cells, and if you are like me in medical school and through my neurology residency and my critical care fellowships, I always thought that the arachnoid layer was this layer of cells that sat along the dura and that had little tentacles that went down all the way down to the pia. That was the arachnoid, the spider legs that went down. Turns out that's not the case at all. It turns out that the arachnoid layer is actually, fills in the entire CSF space during development, and it lays down these collagen fibers that go from the dura to the brain. And that over time, wherever those cells don't touch the collagen, they apoptose, and that's the CSF space you develop. So ultimately what you have is a land bridge of meningothelial cells that go from the dura and all the way down to the pia. So we thought that was an interesting cell to study. And there's been some work already done by a group in Switzerland, or in Austria actually. It's been the Nutzner lab that's been doing work on these things. So we found some really interesting stuff. Meningothelial cells make a limited repertoire of cytokines. Not all of them, but they do make IL-6, IL-8, and a couple of other interesting things, including VEGF-A. But we wanted to test what happens when we did this, and we started out with this in cell culture. So we have immortalized meningothelial cells from a meningioma, human meningioma. And what we actually did, we exposed them to myeloperoxidase, as well as peroxide, as well as an LPS, which is a known model of increasing cytokines. We found something interesting, that when you put myeloperoxidase onto meningothelial cells, it actually suppresses them. And interestingly, the meningothelial cells begin to phagocytose apoptotic cells. So they take on this repertory, or this reparative phenotype, which has also now been shown in another model with meningothelial cells. So it turns out that myeloperoxidase is probably not signaling through these arachnoid cells to then signal damage signals to the brain. So then what is? So our next set of experiments is, that was just the neutral lab. So our next set of experiments actually were to say, well, what if we just put neutrophils in there and see if neutrophils do this on their own? And they do. So neutrophils actually cause the release of particularly IL-8, which is what we're most interested in right now. And LPS does too, but neutrophils and LPS do better than neutrophils alone. We also asked the question of what happens do the neutrophils need to touch the meningothelial cells to make that happen? So we actually developed a basket assay where we put the neutrophils in a basket where the fluid could intermingle, but the neutrophils themselves couldn't touch. And we actually found that was good enough. So we know it's a soluble factor in neutrophils that are affecting these meningothelial cells. And we know that, but we don't know what it is yet. So and we've done other experiments using some downstream markers, and this was part of this grant, and we don't have a lot of convincing data about this. We're repeating all these experiments. But we did find that most of the signaling through LPS, and we think most of the signaling through neutrophils, is from TLR4. And TLR4 is a receptor that's very common it's a common receptor for NF-kappa B, which then actually leads to IL-8 production. What we actually found is that it seems to be going through a non-canonical TLR4 reaction, so not going through IRK, and so we think that it's actually going through a non-MITI 66 pathway, and we're just starting to investigate this more fully, but we have to confirm this data. So that's where we are with that. Right now we've got other experiments, obviously, to confirm this data and to look more importantly at this non-canonical pathway. We're doing a big RNA sequencing experiments in the cell culture to see which of the non-canonical enzymes in the cytosol is actually upregulated, to see what signals we're getting. But the second part of this grant was to say, can we make this a treatment? And turns out that myeloperoxidase blockade is unbelievably easy. So that compound on the left is called KYC because it is basically a lysine residue, a tyrosine residue, and a cysteine residue all stuck together. That blocks myeloperoxidase. Really hard to make that a drug, by the way, because it gets hydrolyzed immediately. But AstraZeneca has made some small molecules that work. And we were lucky enough to develop a relationship with AstraZeneca and actually get this compound. And we did this in mice. And we did a couple things, because we know that the rate-limiting step of all this has to do with neutrophils entering the CSF space. And so we gave the MPO inhibitor into the mouse. We did it intrathecally into their CSF space, and we also did it into their blood. And then we looked to see how far the neutrophils got out of the blood. And we actually found that giving it in the blood was the best way to give it, and it prevents most of the neutrophils from leaving the bloodstream. And we think that's actually probably the mechanism by which myeloperoxidase actually prevents this whole syndrome, is it just does not allow neutrophils to get out of the blood into the brain or into the meninges. And it's pretty impressively how much it suppresses the ability of the neutrophils to leave the blood vessels. But obviously that's not what a treatment's about. So our treatment then at the end of the day was, again, using mainly this Barnes maze test, and I have some other tests that we're doing as well, is to look to see what happens when you give a myeloperoxidase inhibitor on day 2 through 4 after a subarachnoid hemorrhage in a mouse. And what we found is that if you look at the black line, the SAH myeloperoxidase inhibitor group, you'll notice that after about day 6, they look just like sham and not like the subarachnoid hemorrhage mice. So we think we have a treatment. What we're proposing to do next, and this is my second to last slide, is we're going to try to do a randomized, controlled, blinded, 2-model, multi-center mouse clinical trial to see if we can show that the side effects and the model effects can be abolished, and see if we can really still get good signal. And if we do, the hope is that'll be the final step before translating this into starting to do hopefully phase 2 studies, because the drug that AstraZeneca uses has already been through phase 1 in some populations. So to sum up, meningothelial cells make this limited repertoire of cytokines. They make IL-8, which we think is probably a signaling molecule. We still don't know how it signals from the meningothelial cells to astrocytes, which we know are the culprit. We're working on that right now in a mixed culture model. We know that there may be other cytokines that are involved as well. And then more importantly, we know that systemic MPO inhibition seems to, in mice, prevent this entire DCI event and can be given after the hemorrhage. And we're hoping that eventually that's going to be the treatment that we're going to go for. So that's all that I've got. And that's my last picture, which is just the same thing. And obviously I didn't do this alone. There are a lot of collaborators and a lot of people who have helped fund my research, but thank you.